Assalamu alaikum students, and welcome to your ophthalmology lecture video sessions. Today we will be talking about the lacrimal drainage system and dry eyes, which is our third differential in the theme of the ocular surface and lid anomalies. This is something that you see quite often in our country, and as you'll find out, this has more to do with the environment that we are in and the level of hygiene that we tend to maintain. And at times either of these conditions is pretty much not something that we can very easily control. We'll talk about the lacrimal drainage system first, and then we'll take up dry eyes. So for Act 1, which is lacrimal drainage system, we will be talking about the structure and function of the lacrimal apparatus. We'll be talking about the various disease types, how the patients present, how we manage, and their complications. So the lacrimal apparatus in its entirety starts off from the lacrimal gland, which is responsible for producing the aqueous or the watery component of the tear film, and the lacrimal drainage system, which is responsible for moving all of the tears out of the eye or the adnexa. So the lacrimal drainage system is made up of the lacrimal puncta and the canaliculi. We'll go over these structures in a bit, the lacrimal sac and the nasolacrimal duct. All of these structures, from the puncta to all the way down to the lacrimal duct, is lined. All of these structures are lined by mucous membrane. The sympathetic innervation is through the superior cervical ganglion, and the parasympathetic innervation is through the lacrimal nucleus of the facial nerve through the pterygopalatine ganglion. Parasympathetic activity increases secretions, while sympathetic activity decreases secretions within the drainage system as well as the lacrimal gland. So this is a very gross overview of the structures we talked about. This is the lacrimal gland. These are the puncti, superior punctum and inferior punctum. And these are the canaliculus. The canaliculi have two bits, a sort of a vertical component and then a horizontal component, and both of them open into the lacrimal sac. And the lacrimal sac continues down into the nasolacrimal duct, which opens into the inferior meatus of the nose. So this is another picture, shows sort of the relationship of the drainage system as well as lacrimal gland to the surrounding structures of the eyeball as well as the nose. There is a part of the lacrimal gland that is outside of the orbit, but generally speaking, at an undergraduate level, we tend to concentrate more on the drainage system rather than the lacrimal gland. We'll talk about the lacrimal gland when we talk about dry eyes, but that would be a sort of a cursory look at it. This is surface marking of the position of the lacrimal sac. This is important for the regurgitation test. We have an entire video of a demonstration of a regurgitation test, which you should have already seen. If you haven't, you should be doing it today. And I'd highly encourage you to go over that before this, so that you have a good idea of what we mean when we talk about regurgitation test and its inference. So this is the medial canthal tendon, which is basically a sort of an anchor for the tarsal plates in your lids. The tarsal plates are the structure that gives your lids their integrity, their rigidity, or their shape. So this is the medial anchor for that. I'm sorry, my eye is a little flickery. It twitches a little because of dry eyes. And the lacrimal sac lies just behind or posterior to the medial canthal tendon. So this is a very good landmark to sort of know where the lacrimal sac is, so you know where to press to do a regurgitation test. And obviously more information on the regurgitation test in the clinical demonstration video. These are two animations which are just to show you the association of the drainage system together with the eyeball, the canthal tendon, as well as the bony landmarks that are important as we shall just see in both of these animations. So the first one basically is to show you the position of the canthal tendon, which is this structure right here, and the lacrimal sac, which is here. So these are the two tarsal plates, the one in gray, which gives the lid their shape, and these are the canthal tendons, or the medial canthal tendon. It's also called the medial palpebral ligament, but the medial canthal tendon is something that's more commonly used. And this brown structure is the drainage system. This part right here is the sac. These are the canaliculi opening into the sac. So this animation was to show you the association of the medial canthal tendon to the lacrimal sac. This animation shows you the bony location of the lacrimal sac and the opening of the nasolacrimal duct. So this is the lacrimal sac. This is the lacrimal gland right here. And this is the opening of the lacrimal. I'll just bring it back here. Here we go. This is the opening of the nasolacrimal duct into the inferior meatus of the nose right here. One thing that you might have noticed when we were looking at this video towards the beginning was the position of the lacrimal gland. I'll just show you that thing in a second. Here we go. So the lacrimal gland basically has a part that lies outside of the orbit, which is this part. It is actually very slightly palpable at the superior and the outer edge of the orbit, just beneath the bony margin. Again, as I said, it's not of a very high value at an undergraduate level, but just to sort of complete the anatomical description, the lacrimal gland has an orbital part and a palpebral part which is located outside of the orbit. And now we shall move on. We shall move on to the discussion of the drainage system, which is going to be the focus of the first part of this discussion. And as we said, the drainage system is composed of the puncti, which is the opening of the lacrimal canaliculi onto the lids. The canaliculi has a vertical component and a horizontal component, and they open into a common canaliculus, which opens into the lacrimal sac. The lacrimal sac continues down as the nasolacrimal duct and opens into the inferior meatus of the nose. And what this system is designed to do is to allow one-way flow of tears from the eye all the way down into the inferior meatus of the nose, and it does that by the assistance of valves. The two most important valves are shown here, which is the valve of Rosenmuller and the valve of Hassner. The valve of Hassner is closer to the termination of the nasolacrimal duct in the nose, and the valve of Rosenmuller is where the canaliculi open into the sac. And they're just like cardiac valves, and they allow only one-way flow of tears, so that there is no regurgitation of fluid upwards through the system into the eye normally. It will obviously happen under certain pathological conditions and even certain very peculiar physiological conditions. I'll give you the example. If you take a fizzy drink, something with like Coke or Pepsi or 7-Up, anything that you want, and if you remember taking one as a kid and you take one and you drink a lot of it, especially with a lot of fizz at the top, sometimes the fizz actually came out of the puncti. That is actually the gas that rises through the system and through the valves and enters into the eye. So you get a little bit of fizz. I don't know if it happened to you. It's happened to me multiple times, and that is simply because the gas is sort of lighter than the fluid. It is sort of able to traverse the system and out of the eye, which is obviously not something that's totally pathological. It's something that is happening simply because as a child, this system is sort of smaller, your valves are sort of weaker, so they allow some regurgitation of gas. And I'm telling you, this is something that might not have happened to you, so something that probably only happened to me or people that were around me. Anyways, until you have a pathology or an issue with the nasolacrimal system, it is designed to allow only one-way flow of tears from the eye towards the nose. How this system works, this is a diagrammatic representation of the same. So these are the tears in your eyes. These are the canaliculi. This is the lacrimal sac, and this is the valve that we saw here, the valve of Rosenmuller. So we'll see how the tears are pumped from the eyes to the lacrimal sac and down the nasolacrimal duct into the nose. But right now, what we are concentrating on is how this valve works. So these are tears, and when the eye is pumping the tears, we'll see how that happens in a bit. They move from the eye into the sac, and this valve is designed to allow that movement. But the way they prevent, or how they prevent regurgitation, is very similar to how cardiac valves work. So imagine for a bit that there are no valves here. So what would happen is any fluid can simply move back into the eye from the lacrimal sac, which is not good because the sac is connected to the nose, and it has a lot of it produces mucus itself because it's lined by mucus. So whatever is in your nose can actually enter into your eye, which could be really bad because A, it will disturb or disrupt the tear film. B, it could be a source of potential infection. So the way these valves act is that it resists the backward flow by closing their leaves, just like cardiac valves do. The valves are oriented in a way, or their leaves, the valves, the leaves of the valves, just like cardiac valves. They are designed in a way so that if there is back pressure, under normal circumstances, we're not talking about a pathology where there's an obstruction or something. Under normal circumstances, if there is a little bit of back pressure, these valves close so that fluid does not travel in the backwards direction from the sac into the nose. So this is how this valve, and together with the valve of Hassner, prevent flow of fluid in the opposite direction from the nose into the eye. So before we go on and talk about how the tears are pumped from the eye to the drainage system and then into the nose, there are just two terms that we need to clarify. One is lacrimation and the other is epiphora. Epiphora is used to describe a watery eye that occurs because there is something wrong with the drainage system and the tear production is normal. Lacrimation is described as watering from the eye because of excessive production of the tears in presence of a normal drainage system. Epiphora occurs because there is something wrong with the drainage system. Lacrimation occurs because there is excessive tear production for some reason. At one time, these two terms were used exactly like they've been described here, but now they're used interchangeably. The reason I put them here is that if you read texts or books, they are defined as such, but when it comes to their usage, they are used interchangeably, and that at times becomes confusing. Don't be confused. This is what these terms mean, but they are used interchangeably. So many times people talk about lacrimation, and it could be because of an abnormal drainage system. Many times people say epiphora, and it could be because of excessive tear production. The technical definitions are here, but do remember that at times and in places, they would be used interchangeably. So don't get confused. Now, let's talk about how the tears are pumped from the eye to the lacrimal drainage system, i.e. the function of the lacrimal pump. And for that, you need those valves which ensure one-way flow of tears, and also an intact orbicularis oculi muscle and its nerve supply. How these two things interact, we'll just see through some diagrams. But there is a part of orbicularis oculi which is called the lacrimal part, which attaches itself to the lacrimal gland, and it assists in pumping of tears from the eye to the nose. And this is a diagram that shows the orbicularis oculi muscle, and this green structure here is the lacrimal sac, and the blue structure behind it is all the fascia that is surrounding the lacrimal sac. So this muscle is the palpable or the lacrimal part of the orbicularis oculi. The lacrimal sac lies right here, and this is basically the lacrimal part of orbicularis oculi. It's also called the preceptal part. And the pumping is dependent upon an intact and a working orbicularis oculi together with its nerve supply. So let's see how this pumping action actually works. And this is a again, the same diagram that we saw before when we talked about how the valves showed one-way flow of the tear. So this is tear film, and this is your eye, which is open. And when the eye is open, the orbicularis oculi muscle is relaxed. Remember, orbicularis oculi closes the eye. So when the muscle is relaxed, it is not pulling on the sac, so the sac is collapsed. It's all flat. And when you close your eyes, so these are the valves that we already talked about that allow one-way flow of tears. When you close your eyes, the orbicularis oculi contracts, and the part that attaches to the lacrimal sac, the preseptal part or the lacrimal part, contracts, and it pulls the sac. As it pulls the sac expands and creates negative pressure. And this negative pressure pulls all of this tear film into the sac. Now the sac is full of tears, but we need to push it down into the nasolacrimal duct. So we need a mechanism to contract the sac, or so as to pump the tears that have collected in the sac down into the nasolacrimal duct. And that happens when you open your eye, the orbicularis oculi relaxes, the sac collapses again, and as the sac collapses, tears are pushed down into the nose. And at this point, it is the valve of Rosenmiller right here, this valve, that prevents backflow of tears into the eye as the sac opens, and it only allows tears to go down because the valve of Rosenmiller, which is right here, opens, and this valve closes. So briefly again, eye open, orbicularis oculi relax, sac is collapsed. Eye closes, orbicularis oculi contracts, pulls the sac opens, creates negative pressure, all of the tears go into the sac. When the eye opens again, orbicularis relaxes, sac collapses. As the sac collapses, it pushes the tears down into the nasolacrimal duct, and this valve right here, the valve of Rosenmiller, prevents regurgitation of fluid under normal circumstances back into the eye. And the valve of Hassner, which is located right here at the terminal end of the nasolacrimal duct, opens to allow the tears to go into the nose. So this is how the lacrimal pump functions, and it requires an intact orbicularis oculi together with its nerve supply, which is coming from the seventh nerve. We are going to start our discussion of the diseases of the lacrimal system, and we will start off by classifying them. So we have congenital condition. We talk about only one, which is a congenital NLD block. And we will also see what happens when this block leads to an infection within the lacrimal sac, which is called acute dacryocystitis. The acute dacryocystitis results as a consequence of the nasolacrimal duct block. The acquired conditions include lacrimal pump failure, acquired nasolacrimal duct block, acquired NLD block, and an acute and a chronic dacryocystitis. Now, the thing to remember here in the acquired conditions is that these conditions, excluding lacrimal pump failure, which has a different etiology, the other conditions start off with an acquired block of the nasolacrimal system, which then lead to an acute dacryocystitis, which over time would lead to a chronic dacryocystitis. So it's a block first leading to inflammation, and that inflammatory process makes the block first because inflammation eventually is going to be associated with fibrosis, which would make that block even worse. So it's a block followed by inflammation, which makes the block worse. It is possible for the inflammation to happen initially and cause a block, but that is not as common. In fact, the other pathway, the one we talked about before, is so much more commoner, which starts off with a block, leads to an inflammatory process which makes the block even worse. We'll talk about congenital conditions first, and that is congenital nasolacrimal duct block, or a congenital obstruction of the nasolacrimal duct. This is a rather common condition, as we talked about, seen in 5% of newborns, and it could be unilateral or bilateral. The good part is that by following very simple things or very simple management principles, most of these conditions, 90% of these conditions in newborns, is spontaneously resolved by 1 year of age. The part of the nasolacrimal duct that's blocked is the distal end, the one that opens into the nose, and the reason is that it fails to canalize. These passages canalize very close to birth, and the distal end, the one that opens into the inferior meatus of the nose, fails to canalize, which then leads to a blockage in the entire drainage system of the eye. How does the child present? Well, obviously with a mom or a guardian or a parent, or somebody has to bring the child in. And they usually complain of a sticky eye, and the eye has a really mucoid discharge. And that is because the tears aren't being drained away because of the blockage of the nasolacrimal system, and all of the tears that are accumulating make the eye really sticky because they have a lot of mucus in them. And if you do the regurgitation test, it'll be positive. We have an entire clinical demonstration of the regurgitation test, and I strongly recommend, again, you see that before continuing on. That helps in understanding the passages and how does the regurgitation test is done and the mechanisms behind it, but we'll talk about it briefly here as well. So it's a sticky eye with mucoid discharge with a positive regurgitation test. And because the eye is full of a mucoid discharge, because the drainage is not happening, it forms a very good medium for an infection, together with the fact that the debris that's accumulating in the eye is not getting drained as well, whatever is in the environment. So you can develop a conjunctivitis very, very easily. And a bacterial conjunctivitis is something that's commonly seen. And this bacterial conjunctivitis can also later involve the lacrimal sac to cause an acute dacryocystitis. And this is the thing that is the most worrisome part of this entire congenital NLD block, because this dacryocystitis or the conjunctivitis can actually cause cellulitis as its complication. It can spread to soft tissues of the lid, which is cellulitis. That infection from soft tissues can extend behind the orbital septum and then can cause an orbital cellulitis, which can spread to the brain and cause meningitis and even death. Rare, extremely rare, but still possible. We'll talk about complications in a bit as they come along. So this is an eye with mucoid discharge and sticky lashes. This is acute dacryocystitis. You can see an inflamed and a hot swelling right here, which is red and is definitely going to be tender and painful, which is because of the infection of the lacrimal sac, dacryocystitis. So investigations, again, as we talked about, positive regurgitation test, simply because the tears cannot drain to the nose. The lacrimal sac is full of tears, mucus, debris, and when you press on it, the valves of Rosenmuller, the one that prevent regurgitation back towards the eye, the one that were located where the common canaliculi or the canaliculi open into the lacrimal sac, get overwhelmed, and the fluid simply pushes back into the eye. We'll just see how that happens in a bit. The other thing that you can do in order to figure out, is this being caused by an actual block or a lacrimal pump failure? We talked about lacrimal pump before as to how it is crucial in pumping all of the tears into the lacrimal sac. And obviously, if you have a pump failure, tears won't move into the lacrimal sac. That can result in a negative regurgitation test, but just to be sure, in children, you can do a dye disappearance test, but it is not done. The reason it's not done, it's very difficult to perform in young children. You have to give them anesthesia or do something called EUA, which is examination under anesthesia. It's usually not required because, as I said, this is a common condition, and the diagnosis is staring you. So it's easier just to do a regurgitation test and move into the management phase rather than doing a dye disappearance test. It's only mentioned here because this is something that can be done. And what you do is you put some fluorescent dye into the eye, and in 5 minutes, all of it should be pumped into the lacrimal system. If it's not pumped into the lacrimal system, something is wrong with the lacrimal pump. Again, it's not something that's done. It's not something that's even generally recommended, but it can be done. So if it can be done, it's listed here, but you don't really have to do it because the diagnosis is staring you in your face. So the regurgitation test, this is the anatomical landmarks that you can follow so that you know where to press properly or to exert pressure so that the regurgitation is elicited. And this is how regurgitation is elicited, or this is why regurgitation occurs. So we have seen this picture before. This is the valve of Rosenmuller. This is the normal flow of tears from the eye down the sac to the sac down through the nasolacrimal duct. And what has happened now is that there is an obstruction, and that obstruction would cause accumulation of tears, mucus, debris within the lacrimal sac. Now, the lacrimal sac is full of fluid, and any pressure over it, i.e., when you are starting off with a regurgitation test, you press with your little finger, and that additional pressure of fluid that's accumulating within the sac would overwhelm these valves, and the fluid will regurgitate back into the eye. They cannot flow downwards because of the pressure, because this obstruction is stronger than the valves. Stronger, I mean it is more formed. It will not allow fluid to move down, and it's not allowing this collected fluid to move down. There's only one way for the fluids to go, and that is back into the eye by overwhelming these valves. And since this is a child, the valves are sort of not that well developed, they are weaker, so regurgitation is something that's easily seen. Regurgitation is also seen in adults because these are really small valves, and they're not really designed to sort of withstand a lot of pressure. So this is how regurgitation happens. Again, more details when in the clinical demonstration of the regurgitation test. So what do we do? The best thing about this disease is, as we talked about before, is that most of these cases spontaneous resolve. So the best form of management is effective communication. Your communication skills are just as important as your clinical competence, and you need to reassure that this condition does resolve on its own by the time the child is 1 year of age. The mom is usually worried, oh my God, 1 year of age, my child is only a month old or 2 months old or 3 months old, and I'll have to wait, what about another 9 months or 10 months or 11 months? And this is where your ability to effectively communicate come in. You need to tell the parents or whoever is brought the child in that yes, this is something that you will have to do. You'll have to show some patience and perseverance and follow instructions that we give you, because intervention is really not required, because these things resolve, and 1 year is the deadline. It can resolve even before that. What we tell them to do is digital massage, and what digital massage is just like regurgitation. Keep applying pressure, and eventually that pressure can help overcome the obstruction, simply because when you keep on applying pressure, it is going to apply some force onto the obstruction that's happened, or the failure to canalization that has happened, and it would help open it. And the way to do it is you tell the mom to clean the eyes and keep the eyes clean so that there is no mucus, which also helps in preventing infections. And also that the mom should clean her hand and warm the hand against the palm, and just gently press in the sac area with an upward motion or a downward motion, or a rocking motion is the best way. And what would that do is that would apply pressure on the sac and the pressure on the obstruction, and would help open it. And you need to do it till the ear is up. So I usually tell them to do it 5 to 10 times in one sitting, 2 or 3 sittings, not to apply too much pressure so as to damage things in the area. Just apply a firm amount of pressure so that there is some force transmission into the drainage system. And this hastens the process and would help open the passages quicker. If you have an associated infection, you need a topical antibiotic. The antibiotic of choice is tobramycin. It's usually 3 times a day. About 7 to 10 days, it is all that requires. But you keep the eye clean and you continue massaging once the infection clears. And what if you develop a acute dacryocystitis together with a block? Well, then you need to treat the acute dacryocystitis, and that is usually an oral antibiotic, amoxicillin and clavulanic acid. I put augmentin down sometimes, but then many of the students would argue that I am putting a trade name down, so I sometimes use generic, sometimes trade names. Amoxicillin with clavulanic acid is something so that you can control a staph infection with, and together with non-steroidal anti-inflammatory syrup, something like Brufen works. You can also give a topical antibiotic to prevent a conjunctivitis together with a dacryocystitis, and most of the time they do tend to occur together. And once the eye is okay, the inflammation has resolved, you continue massage, clean eyes, again follow the same process as before to hasten the opening of the system. What happens if by 1 year of age nothing works? So at 1 year of age, at 12 months, what you do is something called a probing and a syringing. And before you do a probing and a syringing, we'll just see what that is. You need to ensure that there is no active inflammation in the eye. If you do one probing and syringing at 6 months and it fails, you take one more attempt at, you do one probing and syringing at 1 year of age. And if it fails, you do another one 6 months later at about 18 months of age. So that's step 2 and 3. Step 1 being massage till 1 year of age. Step 2 is at 1 year of age, you do probing and syringing. Step 3, if required, is repeat probing and syringing 6 months later. So if you still can't do it, and it at 18 months your second probing and syringing has failed, you do something called lacrimal intubation. That can be done anytime after 18 months. If lacrimal intubation is not possible, you do something called a dacriocystorhinostomy, which is creating a new passage between your drainage system and the nose so that the tears have an alternate way of flow. Dacryo meaning tears, cysto meaning lacrimal sac, rhino meaning nose, osteo meaning opening in a bone, ostomy. So this is how probing and syringing is done. So probing is done using a probe. I'll show you a video. And what you do is you pass the probe through the lacrimal canalicular system, the vertical part, then the horizontal part, and then down into the nasolacrimal duct. The aim is to use this probe to overcome the obstruction. You don't do it before 1 year of age because these passages are really fragile. You don't want to create an artificial passage. You don't want to damage these passages so as to incite inflammation and make the block even worse. And once you have done this, you can put some fluid, irrigate some fluid to see if the passage is open or not. If this doesn't work twice, at 12 months and then at 18 months, you do something called lacrimal intubation, which is very similar to probing, but rather than just putting a probe in, we put a probe in which is followed by 2 silicone tubes. And these silicone tubes remain in the nasolacrimal system for quite a bit of time so as to provide a passage through which tears can escape. The reason that probing fails is that when you pass the probe out of over the obstruction into the nose, it's a really fragile passage, and although you have opened it, you probably damaged the passage a little bit, which causes inflammation, which blocks the passage again. So what intubation does is it provides tubes, or it puts tubes in the system so that even if you're damaging something, the inflammation cannot occur over tubes. These are silicone tubes which are inert. They themselves cause no inflammation. So even if inflammation happens, it cannot happen at the point where the tube is. So when you remove the tubes a little later, anywhere between 6 weeks onwards, 6 to 9 to even 10 weeks, that's the duration that the tubes are in, so that to ensure that whatever inflammation has to take place, it takes place around these tubes. So when you remove the tubes, there's still a little bit of passage through which the tears can move out. So this is 6 to 8 months later through which the tube is removed. So 8 months is slightly 32 weeks. So not 12 weeks, it's maximum of 32 weeks that you can leave the tube inside. So this is the silicone tube, and this is attached to probes, and it is left in the system. I'll just show you a couple of videos as to what it all entails. This is probing. So the probe is first passed vertically through the vertical part of the canaliculus and then through the horizontal part of the canaliculus. And the baby is obviously under anesthesia. And then it's passed through the horizontal path. And you keep on passing it until you hit the bone. You pass it all the way to the lacrimal sac, and you hit the bone on which the lacrimal sac is lying, and then you pass it vertically down into the nasolacrimal duct. And you have to apply a little bit of pressure to overcome the obstruction. So when I talk about the bone here, I'll just pause the video. What I mean is when you're passing it horizontally, you go through the canaliculus and you go through the sac. How do you know you've reached the end of the sac? You hit the bone, and this bone is the bone of the lacrimal fossa in which the lacrimal sac lies. So let's just move on to where it was. So we are passing it down. And now we want to see if we have opened our passage. If you have an ENT assistance with you, you can do an endoscopic nasal examination like so, and you can actually see the distal end of the probe as it appears through the inferior meatus, the opening of the nasolacrimal duct in the inferior meatus right here. You saw that, here we go, this metallic probe, the end of the probe appearing in the nose. So you can put some fluid in, as we have put some fluorescent dye in this case, so just to ensure that the passage is really open. So this is how probing and then syringing is done to open a passage that has failed to canalize by itself at 1 year of age. And if one probing fails and the second probing fails, you can do something called intubation. So this is the tube, the silicone tube attached to two probes, and the probes are going to be passed through the superior and inferior punctum to the canalicular system, to the sac, into the nasolacrimal duct, and out of the inferior meatus of the nose. So this is passing through, I think, the superior canaliculus to the sac and then out into the nose. And this is a hook that you can use to catch the probe, and here we go. If you don't have a hook, you can use the scissors, and this is scissors, forceps, artery forceps used together with the hook. You can use artery forceps on their own if you don't have the hook. So this is being passed through the inferior canalicular system into the sac, and then finally down the nasolacrimal duct and out of the nasal cavity. And again, this is the hook that's being used together with artery forceps. You can just use an artery forceps if you don't have that hook. This is where an ENT surgeon is valuable on an endoscope, so you can just see the probe and pick it out easily rather than searching for it. Here we go. So both of these probes are now out through the inferior part of the nasolacrimal duct. And what we do is we cut the probes off and we tie the distal end of the tubes right here somewhere. And here the tubes are being tied. And as you can see, I'll just bring it back a little bit. We don't want to see you. This is the tube as it is passing through the upper and lower punctum into the canalicular system and to the sac and down to the nose. So as the obstruction is somewhere in the distal end, somewhere here, and even if you've caused a little bit of inflammation by passing the probes, whatever inflammation will occur around these tubes, and these tubes are going to be in the eye for quite some time. So the inflammation is really not going to be all that what you might call devastating or cause of obstruction, because they will be happening around these tubes which are inert. So once the tubes are removed later, there'll still be a passage around these tubes which would allow tears to flow through. So this is how intubation is done. If intubation fails, we'll do dactyocystorhinostomy, and we'll discuss that together with acute management of an acute nasolacrimal duct block, because it's sort of more relevant there. Probing works 90% of the time. A second probing would work even more, and an intubation would even have what you might call success. I honestly haven't had to do a dactyocystorhinostomy because of a congenital obstruction. Most of the time, 90% of the time, simple massage works. If massage doesn't work, then probing works. And I think I've only had to do one intubation to sort of open a passage up in a baby, where massage as well as probing had failed. So what are the consequences of a congenital obstruction that's left untreated? We've already talked about conjunctivitis and acute dactyocystitis, and we've also talked about preseptal cellulitis as to how conjunctivitis and acute dactyocystitis can involve the soft tissues of the lid, which can cause or extend to behind the orbital septum, which is the sort of a barrier between the lid tissues and the orbital tissue. the infection can spread behind the orbital septum and can cause an orbital cellulitis. And from an orbital cellulitis, it can spread onto the central nervous system and cause meningitis, cavernous sinus thrombosis, and even death of the child. So as far as the management of preseptal cellulitis and orbital cellulitis is concerned, we'll talk more about those when we talk about cellulitis in general. But preseptal cellulitis in children requires hospital admission, assuring a diagnosis that the cellulitis is preseptal and starting proper antibiotic therapy. Orbital cellulitis always requires an admission. Just as a preseptal cellulitis, the route of antibiotics is usually intravenous, because this is an emergency, because inflammation within the orbit can compress the optic nerve and quickly spread onto the brain. This is a rather ophthalmic emergency, orbital cellulitis. Once it becomes a meningitis, it is more, if it does, then it is more a domain of a neurologist. But more discussion on preseptal orbital cellulitis and orbital cellulitis in its management in the appropriate section of cellulitis discussion. So just to get a little bit better understanding of preseptal and orbital cellulitis before we discuss it in the discussion of orbital cellulitis, this is just a small animation showing you the orbital cellulitis, the orbital septum. This is the orbital septum, which is shown in this cream whitish color. And this originates from the margins of the bony orbit. It's actually the continuation of its periosteum, and it merges into these tarsal plates, these gray color structures, which form the major skeleton of the upper and lower lid. So it forms a barrier between the soft tissues of the lid and the orbit, because behind the orbital septum is the orbit and all the tissues within the orbit. These things that you see here, these are the fibers of the levator palpebris superioris as it pierces through the orbital septum and attaches to the tarsal plate of the upper lid. So if we just see the animation, you can see that this orbital septum is a barrier, and if I remove this barrier, behind it is the orbit. And this orbital septum is basically what contains infections in front of it, which will come up in the picture here. So if you have soft tissue inflammation in the preseptal area right here in front of the orbital septum, the lid soft tissue, those inflammations are preseptal cellulitis, which can be as a result of an acute dacryocystitis. That preseptal cellulitis, if severe enough, can overwhelm this orbital septum and reach the orbital area and become orbital cellulitis. This is especially true in children where the orbital septum is not that well developed. It's also sort of not as strong as that in adults. So children are more prone to getting an orbital cellulitis from a preseptal cellulitis, which itself can occur from an acute dacryocystitis. And that is why, just like all partitioning tissues, like the compartments in your arm, this orbital septum is also relatively avascular, so as not to be a source of transmission of infection itself. We'll talk more about preseptal and orbital cellulitis in the discussion of cellulitis, which is going to come up real soon, and we'll develop a better understanding then. Now we'll come on to acquired diseases, and of the acquired diseases, the first one is the lacrimal pump failure, followed by an acute and acquired NLD block, followed by acute and chronic dacryocystitis. And as we talked about before, it is, excluding lacrimal pump failure, it is a block that leads to inflammatory conditions, making the block worse. Although it is possible for the inflammatory conditions to themselves cause a block, the most usual presentation, the common presentation, is a block leading to inflammation, which compounds a block. So we'll talk about lacrimal pump failure first, and lacrimal pump failure occurs because either the seventh nerve or the muscle are not appropriately working. There are many causes of these. Bell's palsy is a rather common cause of seventh nerve palsy, and followed by tumors or trauma or other inflammatory processes that damage the seventh nerve. Which is the nerve that supplies the orbicularis oculi. So it's a damage to the muscle or the nerve that causes the lacrimal pump failure, and it results in a watery eye simply because the tears cannot be pumped into the lacrimal system. So this is technically epiphora. But remember, epiphora and lacrimation can be used interchangeably. And the regurgitation test is negative because there is really nothing wrong with the pumping system. The problem lies with the system that is pumping the tears into the drainage system. The dye disappearance test, again, the one that we talked about before, is helpful here. And although a negative regurgitation test almost seals diagnosis, together with symptoms of seventh nerve palsy or damage to the muscle, you can do a dye disappearance test. I think the process is similar. Within 5 minutes of installation of dye into the eye, all of it should have moved into the nasolacrimal system. There should be none left in the eye. If there is, it tells you that, yeah, there is a pump failure. And we read this or infer this together with the negative regurgitation test information that we already have. What do we do? Since the pump has failed and the nasolacrimal drainage system is patent, we need another way of pumping the tears into the nose, and that is achieved by something called a lacrimal bypass tube. It's called a Lest-Jones tube. And what this tube does, it allows movement of tears from the nasal cavity, from the eye into the nasal cavity, bypassing the normal nasolacrimal drainage system, the lacrimal sac and the lacrimal pump. I'll just show you how this tube appears in the eye, and what is it. The way to insert it is through the medial canthus into the sac and then into the nasal cavity. So it basically helps in bypassing the pump, and it is sort of a direct connection so that tears can slowly percolate into the tube and into the nose. It has a sort of a valvular system. This is how it is entering into the nose through the sac, through the medial canthus. This is how it appears at the eye end as it passes through the medial canthus. This is its opening into the nasal cavity, and it allows sort of fluids to move from the eye into the nose, bypassing the lacrimal pump system as well as the lacrimal sac, and draining directly into the nasal cavity. So this is how a pump failure is managed. This is a close-up picture of the Lester-Jones tubes and how it appears at the medial canthus of the eye. It's flush against the eyeball so that tears can sort of percolate into it. Now we'll talk about acute nasolacrimal duct, acquired nasolacrimal duct block. I keep saying acute, acquired, but I do correct myself. We'll talk about acquired nasolacrimal duct block, which is one of the more common presentations of issues with the nasolacrimal system. We are moving on to the second of the four conditions that are a part of the acquired nasolacrimal system disease classification, and this is acquired nasolacrimal duct block. I said acquired, not acute. I make that mistake often, but I do correct myself. So as we have discussed before, that apart from lacrimal pump failure, the other conditions, acute and chronic dacryocystitis, are almost always preceded by formation of an acquired nasolacrimal duct block. And that block leads to inflammation, which further makes the block worse. It is possible for inflammation to occur before the block and inflammation itself causing the block, but most of the time, the majority of the time, it is the nasolacrimal duct block that leads to inflammatory processes. And poor ocular hygiene, together with constant and extensive exposure to environmental pollutants, is the leading cause of an acquired nasolacrimal duct block. And many a times, although it might seem that these are really trivial issues, they are not under our control. And what it does is it leads to accumulation of debris in the drainage system, which may form little stones or just simply block the passage. Stones within any of the lacrimal system, the lacrimal apparatus, all the way from the gland to the nasolacrimal duct, are called dacryolytes, right? So debris accumulation because of poor hygiene, because of environmental pollution, dirt, dust, a lot of smoke because of open flame cooking, or other sources, lead to accumulation of these debris particles into this really narrow passage, and it just blocks it over time. And though you might think, hey, just don't be in a dirty environment, that's not that easy. especially when you talk about people who are involved in this area as a profession, uh, and we don't really provide them with much protection, which is the responsibility of the employer, which in most cases are local governments. And at even people who work at homes are always exposed to dust because of they're involved in cleaning, and we have still not completely moved on to the vacuum cleaner age. A broom, a jhadu, is still the instrument of choice when it comes to cleaning in many homes, even really fancy homes. So it is still a huge problem. And when it comes to ocular hygiene, you're talking about people to whom availability of drinking water is a problem, let alone any other source. So it is difficult to, although it might be considered to be a really trivial issue, ocular hygiene, just wash your face. Environment, just wear glasses, protective glasses, and use a vacuum cleaner, use a machine or something. But it's difficult because you need to take in the ground realities of where you live in, and how people are sort of working, or their working dynamics, when you consider why these diseases occur more here than other places, and why does the treatment, surgical treatment especially, fail for the very similar reasons. Because the surgery is done all right, the patient goes back into a very similar environment and gets a block again. So this block again creates an ideal environment for inflammatory processes and infections to take place, because it's a mucus lined passage. It's full of debris, it's full of mucus. Even the tears that are supposed to drain are not draining properly. It produces an ideal environment for infection to occur, and that infection is an acute dacryocystitis. And if inappropriately managed, and even if appropriately managed, the infection occurs again and again, it becomes a chronic dacryocystitis. So how does a patient present? Well, a patient presents with a watery eye. This is again epiphora, because this is because of a problem with drainage, and a painless swelling in a lacrimal area. The painless swelling is a sac that has distended, and many patients learn how to get rid of the swelling simply by pressing on the swelling, which reduces its size, and they do a self-regurgitation test. And they just do it because they want to press the area where the swelling is, and as they press the swelling, it causes a regurgitation of the fluid that's accumulated in the sac back into the eye. And when you do see these patients, you see them with a positive regurgitation test, and this is developed slowly over time. And they say that the size of the swelling or the size of the sac has been increasing over time. This is how a regurgitation test is, and again we have an entire video. This is how a positive regurgitation test would look like. The regurgitating fluid would have various types of appearance, to clear if there is more water, to mucoid if there is more mucus component to it. So what investigations are required? Well, usually the diagnosis is straightforward, but you can do a diagnostic probing just to ensure that your passage is blocked. And this probing and syringing is very similar to what we saw in the video with the child, but this time it's an adult, so it can be done without anesthesia. Sometimes what happens is when you're passing a probe, it also opens the or bypasses the obstruction, so this can also become therapeutic. In fact, when we talk about management, we again talk about this first, but rather than calling it diagnostic, we call it therapeutic. So after you have done your probing, you can syringe with a bit of fluid to ensure that the passage has passed. Don't use a salty solution because your throat secretions are a little salty to begin with. Management: therapeutic probing and syringing, just as we talked about a minute back. And if that fails, a dacryocystorhinostomy is indicated, which is creation of a new passage between the sac and the nose. And we'll talk about it in a bit. So this is again probing and syringing. It's very similar. In fact, it is exactly like it was done before, except your patient is now an adult, and it can be done under without general anesthesia, so that your patient is awake and this process is being done. If your probing syringing attempts fail, then a DCR is indicated, and they do fail invariably, simply because even if a first probing and syringing is successful, the patient is going to go back in a very similar environment, irrespective of how well you communicate, because it's something that that person is associated with, and it's very difficult to change. That person might improve ocular hygiene a little bit, but as long as all that debris keeps on accumulating, and remember, this is a passage that's been freshly opened, and you have prescribed some drops after that as well, just to ensure that the inflammation subsides. For example, a topical steroid drop for a little bit of time, that passage is still irritated, and if it is again exposed to dirt, dust, etc., it is going to get blocked again, and the patient is going to come back to you. You do the same thing again, he's going to come back to you. So invariably, DCR is indicated, a dactyocystorhinostomy, which, as we have talked about before, is an artificial passage or a surgical passage created between the lacrimal sac and the nose. And just like as we saw in intubation, in setting of congenital nasolacrimal duct obstruction, a silicone tube is passed through the passage here as well, which remains in this newly created passage for 6 to 8 months. The difference between intubation and this is intubation, remember, was passage of tubes in the nasolacrimal system, from the canaliculi all the way to the sac into the nasolacrimal duct and out of the nose. Here, this tube is passed into a new passage. We are going to create a new passage between the lacrimal sac and the nose and pass the tube into that, completely bypass the rest of the nasolacrimal system. The tube is again removed 6 to 8 months so that whatever inflammation has to take place, it takes place around these tubes, so a new passage is created. And this procedure is the same procedure that's indicated if intubation fails as a measure of removing or overcoming congenital nasolacrimal duct obstruction. It is usually performed from the site of the skin. It's called external DCR, but it can also be performed endoscopically from the nose, endoscopic DCR, which is usually almost, well, it is done by ENT surgeons in collaboration with ophthalmologists. In fact, the entire DCR surgery can be done by ENT surgeons, otorhinolaryngologists, simply because the finesse is mostly to do with the nasal part of the surgery rather than the ocular part of the surgery, as you will see in a moment. So what has happened is that there is a block in the normal nasolacrimal duct system as indicated by the red X or the cross, so that there is regurgitation and all the problems. So what we want to do is to create a new passage, and what we want to do is to create that passage between the sac and the nose by breaking the bone in between. So what we do is, this is the new passage. This is your normal nasolacrimal system, canaliculi, common canaliculus opening into the sac. This is the bone between the sac and the nasal mucosa. So this is the wall of the nose, and this is the nasal mucosa. What we do, and this is the area of the obstruction, what we do is we incise through the skin. If you're doing external DCR, we move the soft tissues to the side, we identify the sac, and we cut the lateral wall of the sac right here, break the bone in between, cut the part of the nasal mucosa through the opening that we have created in the bone, the osteotomy, and stitch these two mucosal flaps so as to create this new passage. And then we pass a tube through this passage. This is the same silicone tube which remains in the system for 6 to 8 months, so that any inflammation that takes place through this new passage, the osteotomy, thus dactyocystorhinostomy, that whatever inflammation has to take place here takes place here in that 6 to 8 month period. And when we remove the tube, there should be a passage here, a patent passage through which tears can move. The idea is that you tell the patient that, yeah, we need to ensure that you improve your ocular hygiene as well as your environment. This is how the tube would appear in the passages once the surgery is complete. And as you can see, we have bypassed the normal nasolacrimal passage, and we have created a new passage between the lacrimal sac and the nasal cavity by going through the bone, creating an osteotomy, and then through the nasal mucosa through which our silicone tube passes. The ends of the tube are tight, just like we did in the case of intubation, and the tube remains within the passages for about 6 to 8 months, after which it is removed. Hopefully, you will have a good patent passage after that. Let's see a little video of how this surgery is performed. And first, what we'll see is the marks for the incision. The incision is made, the soft tissue is dissected away. So this is just careful dissection. This is the orbicularis muscle. And a retractor is applied to the wound edge. And what we do, we incise the periosteum along the lacrimal bone, because you'll have to break this bone in order to gain access to the nasal mucosa. This is the periosteum being lifted off the bone. And once the periosteum is lifted off, a bone punch would be used to enter, to sort of punch into the bone to create an opening in the bone. So on the medial side, this side is the lacrimal sac. This is the lacrimal fossa right here. And this is the lacrimal bone. And this is the bone punch, or a bone nibbler. And it is inserted into the lacrimal bone in the area of the lacrimal crest, and nibbles, or the bone is nibbled away. And slowly but surely, an osteotomy is created so that new connection can be established between the sac and the nasal cavity. So this is your nasal mucosa right here, and this is the sac. So the punctum is being dilated and a probe is passed, and this is the sac as it sort of impinges upon its wall. So the sac is just being dilated here. Not every surgeon does this. And then an incision is made into the lateral wall of the sac, and the pus and all the dias come out. Now you have these flaps. This is the probe coming out from the incised sac wall. And now the nasal mucosa is being cut. And as both of the mucosas have been now incised, they will be stitched together like we saw in the diagrams. So this is the nasal side. A flap is created. And this is the osteotomy below it. This is the osteotomy where my cursor is right there. And this is the flap. That's the osteotomy. So this flap would be sutured onto the, this is mitomycin C being applied so that there is delayed healing in this area. Remember, mitomycin C, we used it in trabeculectomy as well, and also pterygium surgery. And not every surgeon does this. Again, this is being done because in this procedure, a silicone tube will not be passed. So they're using mitomycin C instead of that. So the nasal mucosa and the sac mucosa are now stitched together to create that new passage. And now the skin together with the soft tissue would be stitched independently, completing the surgery. So this is dacryocystorynostomy. It's a slight modification of what we saw in the diagrams in which a tube was placed. They are using mitomycin C instead of the tube. It can be used, but as I said, in our country, the environment and the patient circumstances are such that invariably, even a dacryocystorynostomy with intubation, putting a silicone tube in fails. So that is why it is done as a primary procedure, i.e. the first time you do dacryocystorynostomy, you put a tube in the newly created passage. The other option is obviously to use mitomycin C, as we saw in this video, to delay the healing. But when we do it in Pakistan, we usually take the route of just putting the tube in the first time we do it, because the failure rate here is higher as compared to the other countries, more developed countries, and even to an extent our neighboring countries. So the most common complications here are wound infections, and they're covered by oral or IV antibiotics together with NSAIDs. And as I talked about the success rate, the quoted success rate in literature is about 80%. In Pakistan, the failure rate is closer to the quoted success rate. And again, it's not that our surgical techniques are bad, it's that the patient keeps on going into the same circumstances that led to the obstruction in the first case, and the newly created passage can easily be obstructed because of the same reasons. That is why we do intubation as a primary procedure together with dactyocystorhinostomy. We do not wait to do another dactyocystorhinostomy, a second dactyocystorhinostomy, and then put a tube in. It's called a re-DCR. But this is it. This is the way to do this surgery in order to create a new passage. This is the same procedure that would be done in case of a congenital nasolacrimal duct obstruction in a patient in whom intubation has failed. Now we will talk about acute dactyocystitis, which is an acute inflammation of the lacrimal sac, dactyo meaning tear, cyst meaning lacrimal sac. And the most common reason is that there was already a pre-existing block because of hygiene, because of the environmental factors, and the collection of secretions within the block created a nidus or an environment for infection, causing acute dactyocystitis. And acute dactyocystitis can also occur by itself without there being a pre-existing block. But remember, this is the less common of the two pathways, and that is because of a direct infection from, or direct spread of infection from from a sinusitis or a hematogenous spread from the bloodstream. But this is a less common pathway here in our country. In our country, a more commoner pathway is a block leading to an infection. And what you get is a painful and a tender swelling over the area of the lacrimal sac, and a patient might give a history of, there being a pre-existing swelling which was painless, and if the patient pressed on the swelling, i.e. did a self-regurgitation test, the swelling would reduce in size. The patient would complain of discharge and a watery eye, again epiphora. He or she might have a concurrent conjunctivitis, simply because the infection has spread onto the conjunctiva. And they may also present with evidence of the infection spreading to the soft tissues around the eye, the ocular adnexa, i.e. preseptal cellulitis. So this is an acute dactyocystitis. You can see that there is pus within the sac, this yellow area. This is acute dactyocystitis together with preseptal cellulitis. The skin of the upper and lower lid are inflamed and swollen. This is again an acute dactyocystitis. You can see the sac being full of pus. And again, another dactyocystitis. And this time you can also see some level of involvement of the ocular adnexa. So what do we do? Obviously, the way to go is, again, you need an antibiotic together with a non-steroidal, and these are oral to begin with. I've written the trade name here. Don't blame me. It's just to make your life easier. And if oral antibiotics don't work within about a week, switch to IV, because this infection can spread to preseptal, orbital, and then finally to central nervous system tissue. If you have a concurrent conjunctivitis, a topical antibiotic is indicated. The patient is supposed to be told and effectively communicated they need to improve their ocular hygiene, which would include using protective measures to prevent the eyes from getting dirty, glasses, masks, not touch gloves, or ensuring they don't touch their eyes with their hands when their hands are dirty. And if you do get a nasolacrimal duct obstruction after an acute dactyocystitis, after meaning once the attack is over, it's managed just like an acquired nasolacrimal duct obstruction that we did a few minutes ago. Try syringing, probing, and if that doesn't work, a DCR. So the complications, some we have already touched upon, is spread to preseptal and orbital tissue, and then finally CNS involvement, which may be in the form of meningitis, cavernous sinus thrombosis, brain abscesses, even death, and would require immediate neurological consult. Obviously, we have to manage the acute dactyocystitis together with it, and recurrent attacks, repeated attacks would eventually result in chronic dactyocystitis, and this will complicate a pre-existing block, a block that led to an acute dactyocystitis. And that's what we'll do. The final of the four diseases or the conditions that we were going to talk about in the acquired nasolacrimal system diseases is chronic dactyocystitis, the fourth one. And this is recurrent attacks of acute dactyocystitis eventually lead to chronic dactyocystitis, which is more of a fibrotic reaction, because chronic inflammation is mostly scarring and repair. And this is something that presents with a chronically watery eye. There is not much redness, and not much pain, and but you can get an acute and chronic attack. So what you do, you have a chronic dactylcystitis that's fulminating, and another organism which is more virulent comes in and causes an acute reaction, and you treat it just like you would an acute dactylcystitis. This is chronic dactylcystitis, large lacrimal gland swelling with the minimal signs of inflammation. And what you do here is, again, it's pretty self-obvious from the history, but if you really do want to investigate, again, probing and syringing would be indicated as a diagnostic tool. At times it might become therapeutic, but the chances of it becoming therapeutic are much, much less because the block is much more organized now. The two other investigations that were once performed but now are not are dactyocystography and dactyoscintigraphy. The only reason they're mentioned here is because they are mentioned in your book, and irrespective of anything, books are golden. So what is dactylocystography? Dactylocystography is radiologic study of the nasolacrimal passages, and this is an anatomical study highlighting if the passage has an anatomical block or not. And a dye is introduced into the nasolacrimal system, and the films are taken with it. And as you can see, this is the dye being injected through the inferior canaliculus, and it spreads into the entire nasolacrimal system as well as the conjunctiva of the eye, covering the eye. And this, if you see a dye pooling somewhere or a passage which does not fill with dye, that would indicate an obstruction at a point beyond which the dye doesn't fill into the system. So these are the various landmarks. So dactyloscintigraphy is more of a physiologic test. This is based on a radioisotope study. And what it does is it tells you if the passages are functioning properly. So it's not that the passage is already open, it's also appropriately draining the tears away from the eye. So this is how it's done. This is 5 minutes after the dye is introduced. This is 10, 20, and 40. So the dye's concentration reduces over time simply because the dye is being pumped out of the system, and that is what you would like to see, that after a given amount of time, the entire passage should be devoid of the radioisotopic dye. So this is the legend explaining the various structures that you see when a dactyloscintigraphy is done. This is lacrimal sac, this is lacrimal canaliculi, nasolacrimal duct, this is the nasal concha, and finally where the dye drains into the nose is indicated right here. Again, you don't need to do these, and I have never seen these being done in any of the places that I've worked. So how do we deal with the chronic dactylcystitis? Again, antibiotics are not going to be of much use. The only reason that you use it is in the setting of an acute and chronic dactylcystitis, because you don't operate on an acutely inflamed eye. You can try probing and syringing, as we talked about it before. It can be therapeutic and diagnostic, but it's usually not successful simply because the block is pretty much very organized. And a dactylocystorhinostomy is definitely indicated and is done exactly the same way as we saw in pictures and in the video. And a tube is inserted. The complication of dactylcystitis, a chronic dactylcystitis, can be any of the complications associated with acute dactylcystitis, because remember, you can have an acute and chronic dactylcystitis, and any of the complications of that acute attack on a chronic dactylcystitis would be similar to the complications of acute dactylcystitis. Those complications that are specific to chronic dactylcystitis is mucocele formation, which is simply that you have a prolonged blockage leading to a sealed lacrimal system in which pus collects. So you have your canalicular block as well as your nasolacrimal duct blocks. All the pus is just collecting in the system, which produces a mucocele in the lacrimal sac. The other is pyocele formation, which is a mucocele which is infected, and then finally a fistula formation which burst onto the skin, and it would sort of just drain out. It could happen to a mucocele or a pyocele. So this is a large mucocele, and simply if you do a regurgitation test, it won't reduce because it's completely sealed. This is a fistula formation because the collection within the mucocele or the pyocele became so tense that it just had to find a way out. So it broke through to the skin and created a fistula. And now you have an artificial connection between an unwanted artificial connection between the external skin and your lacrimal sac. So what can we do about these fistulas? Well, the first thing to do is to create a passage through which the TS can normally drain, dacryocysto rhinostomy. And then what can be done is, with time, you can, once the TS start draining normally, what is done is, or even at the same time as you are doing a DCR, you take any instrument which is small enough to pass through the fistula, and you make its the borders of the fistula rough so as to incite inflammation and close it by inflammation. You can just put a stitch outside on the skin side. So if this is the fistula and you've done your DCR and you're doing this procedure at the same time as you are doing your DCR, so you put a small instrument through this, maybe your probe, and you just roughen the edges or the walls of the fistula so that as to incite inflammation, which would close it by repair. And then you just put a stitch on the outside so that the outside area is closed. That's how. There are other ways of dealing with fistulas as well. And this sums up and completes our discussion of the nasolacrimal system. The second act, dry eye syndrome, and this is a to-do list of the second act: the definition of dry eyes, the structure and function of tear films, the type of secretions. This is basically basal secretion, reflex secretion, and weeping or tearing. The innervation of the lacrimal gland, the classification of dry eyes, patient presentation, and management. So a dry eye is defined as the state of cornea or the adnexa of the eye in response to a premature breakdown of tear film. We touched upon this when we talked about blepharitis, and we also talked about tear film stability. We also did something called a T-bud test, or a tear film breakup test, when we were talking about blepharitis, specifically posterior blepharitis and anterior blepharitis to an extent as well. It is associated with a variety of ocular and systemic disorders. We've already talked about its association with blepharitis. This is the structure of the tear film. It's described as a tri-layer. The superficial most layer, the one that's on the top, is the lipid layer produced from meibomian glands. Then is your aqueous or watery phase produced by the lacrimal gland. And finally, you have your mucin produced by conjunctival goblet cells. The lipid layer retards evaporation. The aqueous layer provides a medium for oxygen to diffuse onto the cornea. It also provides immunological agent which prevents infection. It's also responsible for generally clearing away the eye, the cleaning function. The mucin basically covers the cornea, fills its imperfections so that there is one smooth layer, and it reduces the surface tension of the aqueous phase so that it can stick onto the cornea. This is briefly the same functions that we just talked about of the various layers of the tear film. There are three types of tearing: basal, reflex, and crying. Basal tearing is something that's always happening, providing enough moisture to the cornea for its nourishment and protection. Reflex tearing is in response to irritation or an inflammation like conjunctivitis or something going inside your eye. And crying or weeping is an emotional tearing, and it has very different composition in terms of it has a greater aqueous phase as compared to reflex and basal tearing. This is the innervation to the lacrimal gland at the cornea as well as the conjunctiva. The parasympathetic system increases lacrimal secretions, and if you are using parasympathetic drugs, it can potentially cause a dry eye as well. So this is a classification of dry eyes. It is generally classified into two major types: aqueous deficient, darker blue, and evaporative lighter blue color. Aqueous deficient is divided into a Sjogren syndrome type and a non-Sjogren type. Sjogren syndrome could be primary or secondary. Sjogren syndrome is an autoimmune disease. I'm sure you've heard of it before. A non-Sjogren type is one which is either your lacrimal gland is not producing enough tears because it's inflamed, it's damaged, it's got a tumor, or there's something wrong with its nerves, the nerve supply. The gland is okay, but the ducts are obstructed. Maybe again there is inflammation, or there are dacrylith or stone formation. There is a reflex block, or there are drugs that are being used. We talked about parasympatholytic drugs which can reduce lacrimal secretions. Evaporate is something in which the tear film is forming but evaporating too quickly. It could be because of an intrinsic mechanism, something wrong with the eye itself, or it could be extrinsic, something else is happening which is affecting the eye. Intrinsic is meibomian gland issues in which there is not enough sebum or oil produced, like meibomian gland dysfunction we have done. You can't blink properly, or the patient does not blink properly to spread the tear film so that it evaporates too quickly. So it's a disorder of your blinking. Or you have a too low a blink rate, for example, as in the case of seventh nerve palsy or Bell's palsy. Again, drugs which can cause excessive evaporation. Finally, we have extrinsic factors, which are factors from the outside. Vitamin A deficiency. You see this, we used to see this very commonly in Pakistan. We still do see this, but not as commonly as before. Drug preservatives, topical drug preservatives, contact lens use, and allergies. All of these conditions are extrinsic conditions that make the tear film evaporate quicker. We'll take up aqueous deficient and Sjogren syndrome first, which is because of decreased production of aqueous layer of the tear film, because your lacrimal gland has been infiltrated by round cells, which is a primary Sjogren syndrome. Together with your lacrimal gland, your salivary glands are also affected. So you have a dry eye and a dry mouth. A secondary Sjogren syndrome is one in which you have another autoimmune disorder which is invading your lacrimal and your salivary glands, like rheumatoid arthritis, systemic lupus erythematosus, and thyroid eye disease. So SLE, systemic lupus erythematosus, RA, rheumatoid arthritis, TED, thyroid eye disease. The other half of the aqueous deficient dry eye was a non-Sjogren dry eye, and this is caused by lacrimal gland not being producing enough tears or because of various reasons. And this is not associated with a lacrimal gland autoimmune infiltration like Sjogren syndrome. So what is happening is you have gland destruction, which is infections, or dacryoadenitis. Dacryo is from tears, adenitis is inflammation, inflammation of the lacrimal gland, trauma, tumors of the lacrimal gland. Lacrimal gland of duct obstruction is again trauma to the duct, stone formation, and then again inflammation. A reflex block is very interesting, which is that your cornea is no longer sending the sensory input to produce tears. Remember, you need an input in order to have an output from the central nervous system. So unless the cornea is sending signals for the tears to be produced, they will not be produced, or the quality or the quantity would be reduced. A better word to sort of describe a reflex block. And one of the reasons of a reflex block is refractive surgery, together with topical anesthetic use and contact lens wear, prolonged contact lens wear. And finally, drugs, parasympatholytics. We've already talked about how parasympatholytics reduce lacrimal gland secretion, because lacrimal gland is driven by or is stimulated by the parasympathetic nervous system. The evaporating type of dry eye was either intrinsic, something wrong with the eye itself, or extrinsic, something wrong from a pathology that was elsewhere affecting the eye. So the most common intrinsic phenomena is basically blepharitis, meibomian gland dysfunction, which is the oily layer which is deficient. It is seen in posterior blepharitis. It is seen in meibomian gland dysfunction, which is a type of posterior blepharitis. Also seen in mixed blepharitis and anterior blepharitis. The other cause is disorder of your lid aperture and blinking. Disorder of blinking, and when you can't blink properly, as in the case of seventh nerve palsy. Lid aperture anomalies are when your eyes are open too much, like in thyroid eye disease, which is because of proptosis, or your eyes don't close properly, lag ophthalmos, in response to an overactive sympathetic system, also seen in thyroid eye disease. You could have your lid margin turn inwards or outwards, as we'd already done, and we talked about ectropion and entropion. In all of these cases, your blinking is affected, or your lid aperture is affected, and can also cause a dry eye, primarily because of exposure. And because exposure causes evaporation of tear film. The longer it is exposed, the more chances of it being evaporated. So this is posterior blepharitis, meibomian gland dysfunction. Actually, this is more of a mixed blepharitis. You can see some scales at the bases of lashes and capping of meibomian glands. This is thyroid eye disease, exophthalmos or proptosis, also called Graves' disease, or thyroid ophthalmopathy. This is lower lid ectropion, which would affect your blinking and exposure and cause a dry eye. And this is finally a seventh nerve palsy. This eye closes properly, this eye can't, leading to, again, exposure, improper blinking, and dry eyes. So now we are moving on to evaporative dry eye and the second limb, which was extrinsic mechanism, something from the outside causing tear film to evaporate rather quickly. And this has a lot of causes, including computer vision syndrome, which is exposure to computers for a really long period of time. And it is basically exposure to light, which causes this type of a dry eye. It causes certain other symptoms as well, and all of those together are referred to as computer vision syndrome, including lethargy, tiredness, simply because the computer is close by. You're constantly converging, your muscles are getting tired. You also have to accommodate for a longer period of time. And the older you get, your accommodation is getting worse and worse. So all of these things together, in addition to a dry eye, is computer vision syndrome. Contact lenses also cause it. Cosmetic use of cosmetics also cause it. Drugs, retinone, which is used in acne, can also cause it. Ocular allergies can also cause it. Nutritional deficiency, of which one is vitamin A, can also cause this. Vitamin A is also called xerophthalmia, and there are 3 stages to vitamin A. Stage 1 is night blindness, when there is not enough vitamin A going around for adequate rod function. Remember, rods are something that work in low light conditions. So the first sign of vitamin A deficiency in the eye is night blindness, followed by keratinized conjunctival epithelium, which is called a bitot or a betot spot. And then stage 3 is corneal erosions, ulcers, and scarring. So it is somewhere between stage 2 and stage 3 that you start getting a dry eye. This is a bitot spot or a betot spot, which is basically your keratinized conjunctival epithelium. You also get that dry, scaly skin and vitamin A deficiency, and this is something like that onto your conjunctiva. And in South Asia, you usually get a betot spot that's like this, in which kajal is stuck. So how would a patient present? Well, he's going to present with one of the symptoms of an associated disease if one is present, and then a common list of symptoms of dry eyes. And it is one of the most common presentations in an eye clinic, and it is generally a bilateral condition because both eyes are equally affected. It can be unilateral if you wear a contact lens in one eye, you're putting a drug in one eye, you have a seventh nerve palsy in one eye. But generally speaking, it's a bilateral phenomena, and it can present at any age. And though obviously its frequency increases with increasing age, and it's again a very difficult condition to cure because of its association with many conditions which tend to linger around and stick around. And your symptoms of dry eye are usually because of deficiency of tears or evaporation of tears, and they're compounded. The ocular symptoms also are compounded by the pre-existing ocular systemic diseases. For example, blepharitis, you have falling lashes. You also have that irritation and gritty sensation. The symptoms of dry eyes are usually present with symptoms of other ocular conditions or systemic conditions that affects the eyes. Like thyroid eye disease, you would have lag ophthalmos, unable to close your eyes properly. So a very sort of a diverse set of symptoms of which you have to tease out these which tell you, yeah, the patient has a dry eye. So you have a gritty sensation, photophobia, irritation, redness, paradoxical watering in evaporative dry eye, simply because as your tear film evaporates too quickly, there is an increased activity from the central nervous system to the lacrimal gland to produce the aqueous phase or the watery phase, which tends to overfill or overwhelm the lacrimal system, resulting in paradoxical watering, which is seen in evaporative dry eye. And this is lacrimation because there is excessive tear production. So this watering is a paradoxical phenomena that is seen in evaporative dry eye, simply because of excessive stimulation to your lacrimal gland in response to an evaporative dry eye, which overwhelms the the capacity of the eye to drain the tears, so you start experiencing watering. And as you will see, and as you have seen before, that these symptoms are very similar to the symptoms of blepharitis and many diseases which affect the ocular surface. So these have to be teased out from the history that the patient is giving, and you have to do your appropriate examination in order to reach a diagnosis of a dry eye. Remember, this is a very common condition. And in addition to these symptoms, the patient might have certain specific symptoms of the underlying cause. For example, if he has Sjogren's syndrome, he would complain of a dry mouth. If he has thyroid eye disease, he would have other symptoms of thyroid eye disease. For example, lag ophthalmos, we talked about. If it's more severe, exophthalmos or proptosis. And if he has vitamin A deficiency, he would have skin issues or night blindness issues. So again, a very diverse set of symptoms, and the patient's presentation is something that you have to tease out these symptoms from all of the other symptoms that the patient is presenting with, and taken together with the examination, it's not that difficult to diagnose a dry eye. It's the management of a dry eye that's more of an issue. So how do we diagnose it? Well, the diagnosis is, as I said, straightforward. You need to tease those symptoms out of the larger set of symptoms the patient is presenting, and understand that these symptoms are associated with dryness of eyes in addition to whatever the patient is saying, because these symptoms are also very similar to the symptoms that you see in a lot of other ocular conditions, especially blepharitis. And blepharitis is very strongly associated with dry eyes. And most of these symptoms, as we talked about in blepharitis, were because of dry eyes, in addition to the crusting, which also caused some of these symptoms. So really, it's just listening very carefully to the patient as he's describing his history or his story, and noting in your mind, yeah, these things fit the diagnosis of a dry eye. If you want to sort of think of or confirm the diagnosis or your suspicion of any underlying associated disease, like Sjogren syndrome, you can get these antibody tests done, which is called salivary gland protein SP1, carbonic anhydrase 6 antibody test, and PSP test. They were older serum tests like anti-Rho and anti-La autoantibody tests, but these newer tests are better for Sjogren syndrome. For tear deficiency test, we can do a tear film production test, how many tears are being produced, and that's called the Schimmer's test. We'll see a video. And if you, for an evaporative dry eye, we can do a tear film breakup time test. We have also seen a video of this and talked about this briefly when we were talking about blepharitis. So let's see a Schimmer's test. A Schimmer's test is done for aqueous phase deficiency, and it is performed in a dimly lit room without much active airflow, so as to minimize the loss of the tear film. And what we do is, there is no anesthetic involved. We take a shimmer strip, we hook it onto the middle of the center of the lower lid, and we ask the patient to not blink and gently close his eyes, and we see how much wetting is done after 5 minutes. If the entire strip is wetted before 5 minutes, we just note the time that it took to wet the entire strip. And normally 15 to 20 millimeter of the strip is wet after 5 minutes. So this is a strip. This is the part which is hooked onto the eye. The patient is supposed to close the eyes 5 minutes, and you take the strips out and you see how much they have been wetted by their discoloration. So this is more than 20, this is less than 20, so normally 15 to 20, so this is about okay. Some produce a bluish discoloration, some just appear like a wet piece of paper. For evaporative dry eye, we do a tear film breakup test, which is stain the cornea with fluorescein, ask the patient to blink a couple of times, and to blink and open the eyes and not close. And we need to look at first area, or the area where the tear film breaks, which is apparent as a non-fluorescent or a non-dye area. So that is the break, and that's all we are noticing. So the normal time, you should have at least 10 seconds before your tear film starts breaking. And this is the same video that we saw before. I'll let the music play this time. These are areas of breakage. So it's about 9 seconds or thereabouts in which the break was seen once the last blink was taken by the patient. So again, this is just to show what I mean by a break in the tear film, the areas which don't have fluorescent, because the tear film is not there anymore. The fluorescent is staining the tear film. Remember, the fluorescent sticks to the tear film. It does not stick to the cornea unless there is a corneal defect in the form of an erosion or an ulcer. Management, and as we've already talked about, there are so many conditions associated with dry eyes that talking about individual management would not be really feasible and would be really boring for you. And in fact, we have done most of these diseases, and we will do some that haven't been touched upon yet. For example, thyroid eye disease, and there are other diseases that you will do when we talk about other clinical subjects: medicine, pediatrics, vitamin A, medicine, Sjogren's syndrome. So these things have been covered, will be covered in ophthalmology or your clerkships. Blepharitis, we have talked about how important the role of hygiene and massage is in blepharitis. A moderating use of computers, electronic devices when it comes to computer vision syndrome, which also includes dry eye. Vitamin A deficiency is curative. And again, the dosing of vitamin A would depend upon the age of your patient. Lacrimal gland inflammations are curable. Tumors might require resection and long-term therapy with substituents, and even something called punctum plugs, which are just coming up. Ectropion and tropion, we have talked about. Proptosis in thyroid eye disease, we have talked how it causes an evaporative dry eye. We'll talk about how we deal with proptosis when we talk about thyroid eye disease. Sjogren's syndrome requires, obviously, management of the autoimmune disease. You will, or you probably already have talked about it in medicine. Allergic conjunctivitis, we have talked about extensively. Contact lens use, again, you can shift to glasses or spectacles. And drugs, depending upon parasympatholytics or drugs for acne, isotoretinon that we talked about before, maybe you can, maybe with the patient, you can talk to the person prescribing or the physician prescribing those drugs so as to prescribe alternates because they're causing a side effects. Remember, dry eyes is something that is based on history of the patient, and family physicians can prescribe lubricants or even manage most of these conditions by themselves without really requiring any specialized instrument in case of a slit lamp or stuff like that. An ophthalmoscope with a magnifying lens is enough at times to even look at blepharitis. So get an ophthalmoscope. It's really helpful. So how do we manage dry eyes? Effective communication with your patient is number one. You need to tell your patient why this is happening, how this is either curative depending upon the condition that he has, if he has an underlying condition, or how we need to manage it. Together with ocular hygiene, which would help in almost all of the cases associated with dry eyes, because it simply expresses tears and cleans the surface so as to make the patient feel more comfortable. Tear substituents, since these are going to be given for a longer duration, preservative-free is the form to go. They're available in drops, lubricants, and gels, drops and gels for daytime, lubricants at nighttime. Drugs that promote tear production, parasympathomimetics, they are very good for aqueous deficiency states, especially in which lacrimal gland needs to be resected or the secretions are really, really suppressed. Punctal plugs, if for severe dry eyes, they are temporary or permanent. They block the puncti so as to maintain all the tears within your eye. And again, very useful in an aqueous deficient eye. These are what punctum plugs are. They're usually made of collagen, and they degrade over time. The temporary ones, the permanent ones, are usually made of silicone, and they stay in for quite a bit of time. What are the complications of dry eyes? Complications of dry eyes can be sight threatening. You have filamentary keratitis, and what happens is that this constant blinking over a very dried cornea causes degeneration of, well, dry eyes causes degeneration of epithelial cells anyways because of deprived nutrition, and that mucus that's being produced as a form of tear film sticks to those degenerated the epithelial cells, and they form little strands on the corneal surface, which is called filamentary keratitis. And every time you blink, these filaments are very painful because they put a little bit of traction on the cornea, and corneal epithelium has free nerve endings, and this is where the defect is. So they irritate those free nerves, and you can get a very painful eye. You can remove them with special forceps. You can also remove them without a Joule's forceps, but it is not the most pain-free procedure. Obviously, once you do that, you give topical lubricants, a lot of topical lubricants. And if these things continue, they cause corneal erosions, ulcers, scarring, and eventually sight loss. So this is what a filamentary keratitis looks like. This is the cause for ulcers. Simply an excessive dry eye causes corneal erosions because of poor corneal health, which causes ulcers, which can be infected very easily. And if the cornea becomes really, really bad, you need to do a keratoplasty, just like we have talked about keratoplasty. Bad cornea, I mean corneal scarring. And obviously, you need to take care of the cause of dry eye first before you do a keratoplasty, or your transplanted cornea would also suffer the same fate as the patient's original cornea. Thank you very much for your time and attention. And if you have any questions, you know where to ask, and I'll see you next time.